Dr. De Lima, it's so good to see you here at Soho,
Same here.
Houston, and thanks for stopping by, spending some time with me on the Heme Pulse. So, I want to talk a little bit about science and a little bit beyond science when it comes to cellular therapy. I'm intrigued by the science. There's a lot of science in there, but I'm also intrigued by science by itself does not lead to patients receiving the treatment.
Absolutely.
There's so much in terms of the acts and all this. So before we go into the beyond the science and the logistics, from a scientific perspective, several years back, I was hearing about this allogeneic CAR T, and nothing has happened since.
Right.
I hear a lot about it. Nothing has happened. Nothing is available to patients.
There is not a commercial
It's
product
not commercially available
today.
So tell us what's happening in the allogeneic CAR T.
So it is to some extent attached to your first point, right? I mean, theoretically, if you have an off-the-shelf frozen product, life would be easier, right? You don't have to collect patient-specific cells and so on. That said, those cells need to be heavily engineered. For example, some approaches have removed HLA, so you knock out HLA genes, so the cells are incapable of causing graft versus host disease. Or taking the T cell receptor, knock it out. But these interventions also make the cells strange, right? I mean, they may or may not be able to persist. They may be rejected. And so these are some of the limitations. But there are a few trials, very promising, that I don't know how close to the finish line they are, but this is still under investigation, especially in ALL and lymphomas.
So, like a primer on allogeneic CAR T, we're talking about taking the T cells from
healthy donors. You got it.
And then you're engineering them.
Besides putting the CAR in, right, using, say, a lentivirus vector to put the chimeric receptor on the cells, you also have to have genetic instructions to, for example, knock out the HLA gene or the T cell receptor genes.
Right.
So these cells become kind of stealth to the immune system, right? I mean, quote unquote. So it's a lot of engineering required.
What are the, where do you think if you have to tell me the barriers for the allogeneic CAR T making it to the commercial space where patients have access, where are the struggles, I guess, to get to the finish line?
Ironically, one of them is the success of the current product, right? So targeting CD19, there is a whole line of products waiting to target CD19. A competition from a strict commercial standpoint is huge, and it becomes even very hard to recruit patients because you already have so many approved products that target the same disease, the same target. So that's one obstacle. So these trials are moving way slower than they were intended to be. That's one. Paradoxal, right? But it is. And the other is, in great part, what I told you, right? I mean, there are limitations, and there is a lot of concern with the fact that these cells may not work as well as an autologous one. Obviously, there is no direct comparison.
We don't know. Yeah.
Right, so it's too early. But I think today the major obstacle to finish these trials is competition.
Yeah.
For natural, right? I mean, the products arrived earlier, blah blah blah.
So now let's go back to the available commercial stuff, which is the autologous CAR T. It's. I'll share with you that back in the day, I honestly never thought we're going to have so many of them.
So fast.
And so fast. I mean, I predicted it's going to be tough to get a lot of them, but
everybody
I was wrong,
did.
which is probably good for patients.
But
my question to you is, with all of these products there, let's focus on how do we make it easier for patients to get them? What are these barriers that we are looking at?
I think that undeniable success that these companies have had, right, to take these products so fast, get them approved. This implied also a regulatory different paradigm, right? We have to acknowledge that the FDA had a role in expediting this, which is fantastic. But at the end of the day, we are seeing a huge, within the United States, a huge racial disparity. You know, the minorities are absolutely underrepresented in this type of treatments, both in the trials and also in the commercial, where we have registries now collecting this information. So clearly there is a process that obviously is not conscious, but somewhere along the way we're not reaching a representative slice of our population.
Do you know why?
Well, social reasons, socioeconomic reasons, for example, right? I mean, I require that you move to close to my institution, for example. Can you do that, you know, for a month, for 2 months? Or people are not aware even of these treatments, depending on where you are, on how much access to information. Be that what it may, the final result is that the proportion of minorities in the current cohort of patients treated with CAR-Ts is this much. Now, if you look outside the US, even in Europe, more than half of Europe simply does not have access to CAR-T cells today. So you think in third world, but no. Developing nations, I'm not going to go there. South America, there is not the access is dismal. So essentially, this type of treatment, which revolutionary as is also opening our eyes to this huge discrepancy of access. Huge.
Yeah. Is there any, going back to the disparities, as I'm listening to you, obviously there are the social aspects, whether it is could be insurance, access, all of these things. Is there anything biologically different in terms of, on the immune level that you guys have studied to suggest, for example, African Americans, Hispanics, Caucasian, something on the molecular level of the disease, or like you can't collect cells, or there's no such thing?
This has to be assumed is social, economical reflection of our problems, right? I mean, let's put it like that.
And now when you look at the number of CAR-T constructs and products available, if we put back now the science hat again, how are you able to determine, for example, for which patient you give which CAR-T, if you have all of that available in front of you? Is this like an impossible question to address?
Everybody has a little bit of a favorite. But there are some considerations. Some of the constructs out there are slightly more toxic. So sometimes you make a choice based on that. So your perceived ability of the patient to tolerate more toxicity. So you're older, you pick product A. You're younger, you get product B. So there are some differences that are emerging. But as is, there is no head-to-head comparison. There are comparison of CAR-Ts with standard of care, but no CAR-T versus CAR-T, as you could say, a prospective study. So it becomes a little bit of what I'm saying, right? A perception and experience.
Yeah. My last question is, we hear a lot, and I know obviously we're in a hematology conference, right? A lot of people are talking about cellular therapy in solid tumors.
Yes.
And as obviously an expert in cellular therapy and immunotherapy, where how do you see that playing out in the solid tumor?
So the cell that's closest to the finish line, since we're talking about commercial access, are tumor-infiltrating lymphocytes. So it's likely that we'll have a product approved in the United States to treat melanoma, meaning, this is an old technique, right? You get the tumor, you slice it, and you grow the cells.
For a while.
You got it. Another one that you mentioned that's taking, but it seems to be very close now to approval for melanoma, possibly for cervical cancer, and then there are tons of trials in lung cancer. So those are the most where, compared to the responses we see here, they are very modest. They are not very huge response rate. These are not genetically engineered cells, but I think they will carve a niche and will be probably the first one that you can say, okay, here's a cellular immunotherapy in the realm of solid tumors. So,
This is really amazing and fascinating. Look, I appreciate you stopping by. It's
pleasure.
This is a teaser to our viewers about cellular therapy and what's yet to come, and I look forward to seeing you at ASH.
I'll see you around.
Thank you.
Thanks for having me.